Sorry, Nad, you are starting the webinar?
No, I didn't
Can
start it from my end.
can you start it? We are already 7:01.
Yes, sure, yeah.
I'm preparing live stream. معقول يا حسام okay.
I think it started already.
No, now he is starting it. He sent me. Okay, خلاص مش الحال. Thank you, Rinad. Okay, so I think Joel, you can start. Yes.
So good evening, everyone, and welcome to our webinar tonight. Tonight, we prepared for you a list of topics, very interesting topics to discuss in multiple sclerosis. So this is a webinar titled Highlights in Multiple Sclerosis Care. And of course, we would like to thank IVPN and specifically the NeuroPsychiatry Lister for really doing all the work of organizing this tonight. We'd also like to thank our sponsor, Novartis, for supporting this educational activity and bringing us all together to further our education tonight on the topic of multiple sclerosis and all the updates we're going to learn about tonight. We'd like to inform you as well that this webinar tonight is also endorsed by the Consortium of Multiple Sclerosis Centers, which always supports our educational activities. And tonight, the CMSC has endorsed this activity all the way from the US. It's my pleasure tonight to welcome a panel of women MS healthcare professionals, physicians, pharmacists, and nurses. It's always a pleasure to have people from all specialties join because we always say it takes a village to take care of MS patients. So, in the interest of time, we will dive right in and tell you that tonight we're going to be discussing multiple topics around the pharmacology of MS care, how to counsel people living with MS, what are the updated treatment guidelines for people living with MS, and specifically talk about the B-cell depleting therapies in MS. I'd like to remind you all that this webinar is CME accredited, and you will receive your certificate of attendance around 1 week after the end of this webinar through email. So, of course, I'd like to welcome all the faculty tonight for joining me, Dr. Maya Zainuddin, Dr. Muna Fakri, and Ms. Gina Lee. I would start with the first faculty of tonight, and the first faculty for tonight is my dear colleague and friend, Dr. Maya Zainuddin. It's my pleasure to welcome her and to introduce her to you first so that she can start with the first lecture of this evening. I'm sure many of you know Dr. Zainuddin, but just to brief you for all of us who might not know her, and so that we can know the background as well and really also be inspired by all the work she's done over the last, I think, more than probably 15 years. So currently, Dr. Maya Zainuddin, she's a clinical associate professor at the Lebanese American University of Beirut. She has been working in the field of MS since 2011 at least. She originally started as a clinical pharmacist and at the American University of Beirut MS Center, which was the first MS center in the region. She originally graduated from LAU, the same faculty or school she currently practices at, with a Doctor of Pharmacy degree with distinction in June 2011. And she eventually passed also the MS multiple sclerosis specialist examination and became the first MS certified pharmacist in Lebanon and the Middle East region. So eventually she also became appointed as the executive secretary of the Middle East North Africa Committee for Treatment and Research in MS, the main acronyms which we all are familiar with. She's also an active researcher, and she publishes multiple articles on MS, specifically around the field of epidemiology and This is what she's also specializing in now in her PhD that she's completing at the University of Limoges in France. Maya, the floor is yours, and we will start with the first topic of tonight, which is the pharmacology of multiple sclerosis. You're muted, I think.
Thank you, Joelle, for this very, very kind introduction, and it's always an honor to be with you.
Thank you.
And thank you for all our attendees tonight, numerous attendees actually tonight. And with no further delay, I will start my presentation and I will discuss the pharmacology of multiple sclerosis. So what are the drugs that we use? But before listing the medication and their mechanism of action, just very brief background about MS. So it's the most common neurological disabling disease in young adult, and it's actually the second leading cause of disability in our young patient. It is a chronic autoimmune disease, and the prevalence of MS is significantly increasing over the past decade, and it actually increased from 2.3 million in 2013 to 2.8 million according to the latest atlas of MS published by the Multiple Sclerosis International Federation. Women are 3 times more likely to develop MS than men, and the ratio is 3:1. And unfortunately, MS is a disease of the young people, so it affects patients between the age of 20 and 40. So this is the peak age of diagnosis. However, any age can be affected by the disease. We have seen pediatric patient diagnosed with MS. We have seen elderly patient diagnosed with MS. However, the peak age for diagnosis is between 20 to 40 years. And it can affect any organ and any system. And that's why the patient will present with a wide variety of symptoms, ranging from blurred vision, weak limbs, tingling sensation, numbness, dizziness, fatigue, depression, bladder and bowel dysfunction, and much more. What is the pathogenesis of the disease? So as I mentioned, it is an autoimmune disease. So we have autoreactive, we have an error in our immune system that we'll see why for a reason or another. And usually this will lead to autoreactive B and T cells. So usually our B and T cells should provide us with immunity and should fight any foreign body that affects and invade our body. However, in patient with autoimmune disease, this error in the immune system will lead those autoreactive B and T cell to cause damage to our own system and to our own body. And in MS, what happened that those autoreactive B and T cells will cross the blood-brain barrier, will enter into the central nervous system, and will cause damage to the nerves. And mainly they will lead to demyelination. So they will remove this myelin sheath, this coat that protect the nerves and cover the nerves. And this myelin sheath is responsible for the action potential to pass and for this electrical activity to pass throughout the nerves, and and this will lead and this will lead to the this will affect the function of the organ that is where the damage occur. So this is another slide about the pathogenesis of MS and why it's important to understand the pathogenesis of MS to be able to understand the mechanism of action of the medication. So really, the pathogenesis of MS is an interplay between genetic predisposition. Many mutations in MS have been identified through genetic study, and mainly we have HLA and non-HLA gene mutation that are responsible of predisposition of MS. Actually, more than 300 gene mutation were identified. So genetic predisposition can lead to the disease coupled with environmental factors. And what are those environmental factors? Mainly vitamin D deficiency, smoking, infection during childhood with Epstein-Barr virus infection, and childhood obesity. All all this, along with genetic predisposition, will lead to an error in the immune system, to autoreactive B and T cell that will adhere to the blood-brain barrier. They will cross this blood-brain barrier and they will cause inflammation into the myelin sheath of the nerves, and they will lead to inflammation, release of cytokines and inflammatory mediator, and this will lead to more damage in the myelin sheath. And if untreated, this demyelination and inflammation will be transformed into axonal degeneration and loss. So it will lead to axonal loss, meaning that this axon will be irreversibly damaged and there is no room to correct this damage. While when in the phase of inflammation, we can still reverse the damage at an earlier stage. So why MS is a serious disease? Because it is a progressive disease that can lead to irreversible disability whenever we reach the level of axonal damage, and this will affect the quality of life of our patient. So 50% of our patient will have depression, anxiety, 50% will have cognitive problem, all patient will suffer from fatigue, 40% will have tingling pain, burning sensation, neuropathic pain. Patients will have mobility, altered mobility, like weakness in their lower and upper extremity, stiffness, spasticity, and this will affect their gait and their walking. And all these symptoms and all these disabling symptoms will lead to decreased employment, and unfortunately 35 to 40% of the patient lose their job because of their disease. And that's why it's very important to treat this disease early on, especially that it affects patients at the age of 20 to 40. So it's the age where people are on the top of their career, and they are, for example, women, they are at the age of getting married, having children. So it's really, we are at, they affect, MS affect people at an age where people, they are at their top of their career and achievements in life. And that's why it's very important to treat and to stop the progression of the disease. And currently we have more than 19 branded disease modifying drugs that are approved for the treatment of MS. How those they differ? They differ by the route of administration. So some are injectables, other they are given as infusion, and other they are given as oral drug. And also they differ mainly by their mechanism of action, efficacy, and side effect profile. And we will go through them quickly. However, the key point that new high-efficacy drugs really are changing the prognosis of MS, and this study shows that the introduction of high-efficacy drug, which occurred after the year of 2010, had led to delaying the progression of disability of MS. So actually 84% of patients had less disability, so less risk of reaching an EDSS of 6, which is EDSS of 6, meaning that the patient is severely disabled and requires devices for ambulation. So after 2010 and after the introduction of high-efficacy therapy, the risk of disability progression and to reach EDSS 6 is decreased by 84% of the patient. And this means that the importance of early treatment in MS and the importance of using high-efficacy therapies in MS. And this is, again, another study that showed that the risk of progression to EDSS4 increased by 7.4% for every year of delayed treatment after the MS onset. So if we delay, every year of treatment can affect the prognosis of the disease and can lead to accumulation of disability and can lead to reaching a progressive stage of the disease. And that's why it's very important to treat early, because tackling the inflammation early in MS with effective drug that we have nowadays is reversible and can significantly improve the quality of life of the patient. This is another very interesting study from the MS base that also showed that using high efficacy drug comparing to platform therapy also is even better, because this will decrease the risk of conversion of a patient to progressive stage, the stage where we have irreversible disability. So treating now with high efficacy therapy, even as first-line therapy, is recommended, because we know that they will have better outcome in terms of prognosis and conversion to secondary progressive MS. What are the goals of treatment? So nowadays, with the availability of all these effective drug, we aim to achieve NIDA, meaning no evidence of disease activity, and this is characterized by the absence of relapse, absence of MRI activity, and absence of disability progression. How do we achieve this? We have several drugs that works on different mechanism of action, whether in the peripheral circulation by killing B and T lymphocyte, or whether on affecting the permeability of the blood-brain barrier, preventing the migration of these autoreactive B and T cells into the central nervous system, or inside the brain by working on the balance between the good and the bad B and T cells. So here are the list of the approved DMTs. Some of them are injectable, the one in blue, and ofatumumab is the latest subcutaneous injection, self-injectable, that is approved in MS. We have the orange drug, they are oral drugs, and the purple, they are the drugs given as IV infusions. And we'll go over them quickly. So those drugs, they are classified as platform therapy and high efficacy therapy. And this is a new nomination for this drug. If I was given this lecture like 2 years ago, I would say first line therapy and second line therapy. However, nowadays this nomination has changed in the field of MS, and the drug that have low to moderate efficacy, they are classified as platform therapy, while the drug that have high efficacy, they are named as high efficacy therapy. So the platform therapy are the injectable. We have interferon and glatiramer acetate. They are all approved for relapsing remitting MS. They differ by their method of administration. They are all self-injectable, whether sub-Q and IM, but they differ by the frequency of the injection. They all have the same efficacy. They decrease the relapse rate by 30% compared to placebo. And the pegylated interferon, which is a new interferon that was introduced to the market a few years ago, it has a large protein molecule that is attached to the interferon, and this is what we call pegylation. And this pegylation will prolong the circulation time of the interferon by increasing its molecular size, and this will lead to longer half-life of the drug, and this will shield this drug from being metabolized by liver enzyme, leading also to prolonged half-life. And this pegylation has led to the decrease of frequency of injection from 12, 15, or 4 injections per month with the old interferon to only 2 injections per month. So pegylated interferon is given one injection every 2 weeks, and without affecting the efficacy. So in terms of efficacy, it still decreased the relapse rate by around 30% compared to placebo. As for safety, all the interferon, they cause flu-like symptoms and injection site reaction, and that's why they are not well tolerated by our patient. We try to help our patient to tolerate these side effects by asking them to pre-medicate with ibuprofen or acetaminophen, take the injection at night, and use appropriate injection technique, gently massage the area of the injection, and of course rotating the site of injection. But despite that, unfortunately, those types of medication are not well tolerated by our patients. Moving to another platform therapy, which is teriflunomide or Aubagio. Teriflunomide is an oral once daily drug. It is a dehydrogenase inhibitor. It inhibits this enzyme involved in the de novo pyrimidine synthesis, and this enzyme is responsible for the proliferation of B and T lymphocytes. So it's actually stop the proliferation of those cells. In terms of efficacy, it decreased the relapse rate by 30% compared to placebo, so it has a similar efficacy to interferons. In terms of safety, it caused increased liver enzyme, hair thinning, and diarrhea. Those are the most common side effects. Moving to another oral therapy, dimethyl fumarate. It is a a daily oral also drug. It comes as a 120 milligram capsule. This is the initiation dose. It should be given 120 twice daily for 7 days. This dose is not effective. It's only used to decrease its side effect. And then after 7 days, we increase to 240 milligram twice daily. This is the dose that we use in MS. It's really exact mechanism of action is not fully elucidated in MS, but we think that it works in the nucleus of the cell to increase the antioxidant response and decrease the inflammatory response. In terms of efficacy, it decreased the relapse rate by 50% compared to placebo. So it has a little bit higher efficacy than the interferons and glatiramer acetate and teriflunomide. As for side effect, GI side effects are the most common symptoms, and they are really very bothersome, especially during the first month. Then they will subside with continuous use of the medication. Also, flushing is a very common side effect of dimethyl fumarate. We usually, as nurses, you should advise your patient to take this drug after food, and especially after fatty food, in order to decrease those side effects, whether the GI side effect or the flushing. Moving to another oral drug, and actually fingolimod was the first oral disease-modifying therapy that was approved for MS. It is an S1P receptor modulator. So in terms of mechanism of action, so what this means, so S1P receptor, they are receptors that are present in different parts of the body, and those receptors, they are present also in the lymph nodes, and fingolimod actually, it will modulate those receptors. It will internalize this receptor and leading to inhibition of the lymphocyte to egress from the lymph node. So what it does really, that it traps, it prevents the migration of these lymphocytes from the lymph node into the peripheral circulation. It will trap the lymphocyte inside this lymph node, prevent their circulation into the peripheral blood, and this will lead to retention of this lymphocyte inside. They will not enter, they will not go into the peripheral circulation, and they will not enter into the central nervous system and cause damage for our myelin sheath. And this retention is reversible, because whenever you stop fingolimod, you will see by doing a CBC that your lymphocytic count will go back to normal level. So in terms of efficacy, also it decreased the relapse rate by around 50% compared to placebo and also interferon. So it has comparable efficacy to dimethyl fumarate and a better efficacy than interferons and glatiramer and teriflunomide. So before initiating your patient on fingolimod, you need to double check that the patient doesn't have lymphopenia. So we should do a CBC, of course, liver function test, because all these drugs, they are metabolized by the liver. There was 2 cases of varicella zoster death, reactivation death in the initial clinical trial of fingolimod, and that's why you have to do a varicella zoster antibodies before starting your patient on fingolimod to make sure that they are immune. And if they are not, you need to ask them to do the vaccine and wait for 1 month before you initiate fingolimod therapy to make sure that the patient had good response to the vaccine. We also do an ophthalmic exam at baseline, because fingolimod very rarely can cause macular edema, especially in diabetic patients. So you need to do an ophthalmic exam before initiating fingolimod to make sure that the patient doesn't have macular edema. And also, the first dose of fingolimod was rarely associated with bradycardia, asymptomatic or symptomatic bradycardia, and that's why you need to do a baseline EKG before starting your patient on fingolimod. Also, the first dose of fingolimod should be taken in the center or in the hospital under monitoring, and usually the nurse is responsible of monitoring the blood pressure and the heart rate of the patient every hour after taking the pill, and patient will stay in the center or in the hospital or under monitoring for 6 hours after receiving his first oral dose. And before discharge, we usually do a repeat EKG to make sure that no bradycardia occur, and then the patient can safely take the drug at home without worrying about the side effect. And routinely, we should do a CBC, liver enzyme, and ophthalmic exam after 3 months. Actually, we have many S1P receptor modulator that have the same mechanism of action as fingolimod that were approved after fingolimod. So fingolimod was the first one, and they differ by their specificity to the receptor. So they all have the same mechanism. However, fingolimod is a non-specific S1P receptor modulator, while, for example, siponimod is a more specific one. It works on S1P1 and S1P5. Ponesimod is the most specific one. It works on S1P1 receptor only, and this mainly affects side effect rather than efficacy, and also it affects the half-life of the drug that I will be discussing in a bit. However, ponesimod, despite that it had a good efficacy, so it decreased the relapse by 30% compared to teriflunomide in its phase 3 clinical trial, its company decided to stop its marketing. So it's not available. Ponesimod is not available, although it is approved for relapsing remitting MS. It has good efficacy, a safety profile that's comparable to fingolimod. However, its marketing was stopped. Moving to siponimod, also another S1P receptor modulator that is approved for relapsing remitting MS. What's special about siponimod is that we think that it can readily cross the blood-brain barrier, so it might have some CNS neuroprotective effect. And actually, siponimod in the EXPAND study was the first drug that shown decrease in the disability progression in secondary progressive MS. So when we looked at the disability progression, it significantly decreased compared to placebo in patients who have active secondary progressive multiple sclerosis. And it was the first drug that was shown effective in this category, and that's why it is approved in this phenotype of patients. Moving to the high efficacy DMTs. So high efficacy DMTs, they are one of the high efficacy DMT is cladribine. So cladribine has a very special mechanism of action. It is an immune reconstitution therapy, meaning it depletes most of the B and T cell. And then after 1 month, our bone marrow is able to reconstitute a new set of B and T cell that we think that they are not autoreactive, so they are free of multiple sclerosis. It has also a high efficacy, and that's why it's classified among the high efficacy DMTs. It decreased the relapse rate by 60% compared to placebo across clinical trial. It is an oral drug that is given only over 2 years. So we give a first course on week 1, a first cycle on week 1 and week 5 or year 1. Then on year 2, we give a second cycle on week 1 and week 5, and it is a weight-based dose. So it is dosed based on the weight of the patient. It comes as a 10 milligram tablet. You need to calculate the total dose based on the weight, and then you divide the number of tablets over 5 days, and then we repeat after 5 weeks, and this cycle is repeated over year 2. And then we don't need to give any further MS treatments or any further cycle of cladribine unless the patient developed any new relapses or a disability progression or showed any new MRI activity. So unless the patient has a breakthrough disease. And actually the extension studies have shown that 75% of the MS patients didn't need any further treatment after cladribine therapy over 5 years, and they remained stable with no need to give any third cycle of cladribine or any further drug. Moving to monoclonal antibodies in MS, and natalizumab was the first monoclonal antibody approved for the treatment of relapsing remitting MS, and it is an IV infusion drug. It comes as a 300 milligram vial that is given over 1 hour as IV infusion every 4 weeks. And as mechanism of action, really natalizumab work on the permeability of the blood-brain barrier, and it prevents the migration of these autoreactive B and T cells of leukocyte from the peripheral circulation into the blood-brain barrier. We also think that natalizumab modulate the leukocyte apoptosis, leading to apoptosis of those autoreactive B and T cells into the central nervous system. Also, it has high efficacy as it decreases the relapse rate by 67% compared to placebo in its AFFIRM study clinical trial. The major concern with natalizumab, so it's usually a safe drug. It can cause some infusion reaction. It is a monoclonal antibody, so we pre-medicate with antihistamine during the first 6 infusion of natalizumab. And we monitor the patient for hypersensitivity reaction for 1 hour after receiving the infusion. However, this is not the issue. The issue with natalizumab is the occurrence of this very rare, serious brain infection called progressive multifocal leukoencephalopathy. So this is a very rare brain infection, viral infection that is caused by an opportunistic virus called JC virus. JC virus is a virus that we catch during our childhood, and it remains dormant in the nerve roots in the brain. It doesn't wake up until the immune system of our central nervous system is low. So until we have immunosuppression of our central nervous system, and this is what natalizumab does for our CNS immunity. So when we have decrease in immunity in the CNS, this JC virus will wake up and will do damage that is similar to MS. So it might lead to disability and even to death if not detected early and treated. This is a serious side effect, can be fatal side effect. However, it's very rare, and the incidence is 4.18 per 1,000 patients of natalizumab treated patient. And throughout the post-marketing of natalizumab, we were able to identify the risk factor that predispose the patient for this very rare side effect. We have 3 major risk factors for PML. The duration of treatment. So all cases of PML that were reported in the literature occurred after 2 years of use of natalizumab. Patient would have used other immunosuppressive drug prior to using natalizumab, so this will also increase the risk of having PML. And the patient should have a positive JC virus, and JC virus can be detected in the blood, and we do this for our patient. We do a JC virus blood test. We take a simple sample of blood and we send it to a centralized lab, Unilab in Denmark, and they will tell us if your patient is positive, has the virus, or doesn't have the virus. So you can stratify the patient whether they have a high risk for PML or low risk of PML. So having JC virus is not a contraindication to natalizumab. You can still give natalizumab for your patient. However, you cannot give the drug for more than 2 years in JC virus positive patient. And because of this side effect, natalizumab cannot be given at home. For example, it should be given in a special centers under a touch prescribing program, which is the risk management program of natalizumab that require that the nurse or the healthcare professional ask and assess PML symptoms for the patient before starting the infusion of natalizumab. The third monoclonal antibody is alemtuzumab. Also, it has a similar mechanism of action to cladribine, but however, it kills all immune cells. So it doesn't only kill B and T cell, but also macrophages, monocyte, neutrophils, plasma cells, precursor cell. It's an anti-CD52 monoclonal antibody that almost kill most, if not all, our immune cell. And then our immune system is capable of repopulating a new set of immune cells free of the disease after 1 month of treatment. It has also a high efficacy. It decreased the relapse rate by 50% compared to interferon beta. Also, it is given as IV infusion over 2 years. So we give a course IV over 5 days, then the next year we give IV over 3 days, and no need to give any further cycles or any other MS therapy unless also the patient develops breakthrough disease. And extension studies have shown that 70% of the patient remained stable throughout 5 years of treatment of alemtuzumab and didn't need any further drug. So this high efficacy and the special mechanism of action is coupled by a serious side effect profile. So alemtuzumab can cause a serious infection, opportunistic infection, viral infection. It can also cause other autoimmune diseases like thyroid disorder, immune thrombocytopenia, and autoimmune nephropathies. And that's why you need to monitor very closely your patient who received alemtuzumab for 3 years after receiving the last dose. So the patients need to come to the clinic and do blood tests like CBC, creatinine, urine analysis, thyroid function on monthly basis, urine analysis for 3 years after receiving the dose to monitor for these autoimmune side effect and infection. Moving to a new class of drug in MS, which are the B-cell depleting therapy. And traditionally, we thought that MS is a T-cell driven disease. However, nowadays, this concept have changed. And now we know that B-cells are involved in the pathogenesis of MS. They interact with the T-cells, leading to reactivation of more T-cells, and more autoreactive will be activated. We will have more secretion of cytokine production, and this will lead to more damage of the myelin sheath. And here, this slide shows the evolution of anti-CD20 monoclonal antibody or B-cell depletion therapy in MS. So the first one used is rituximab. It is an anti-CD20 that is used off-label. It's not approved for MS, but we used it off-label in MS. And it is a chimeric antibody, meaning that it's not humanized, but it contains mouse sequences in addition to human sequence. Then comes ocrelizumab, which is a humanized antibody, but it's not fully humanized. It contains 90% human sequence and around 10% of mouse sequence. Then comes ofatumumab, the latest monoclonal antibody approved for MS, and it is a fully humanized B-cell depleting therapy. So B-cell depleting therapy, they are anti-CD20 that will bind to B-cells through the anti-CD20 receptor, and they will eventually kill B-cells. Ocrelizumab is approved for relapsing remitting MS based on the OPERA 1 and 2 trial that showed a decrease in the relapse rate by 50% compared to interferon, and that's why it is classified as high efficacy DMT. What is special about ocrelizumab, that it also stopped the disability progression in primary progressive MS, and it was the first drug that stopped disability progression by 25% compared to placebo in this phenotype, and that's why it is also approved for primary progressive MS. Ofatumumab is the fully humanized monoclonal antibody, the latest one approved. So they bind to different epitopes, so we think they have different efficacy. And actually, also ofatumumab is a high efficacy monoclonal antibody that decreased relapse rate by up to 60% compared to teriflunomide. Also, this meta-analysis have shown that it has a comparable efficacy to the other monoclonal antibody, classifying it as high efficacy monoclonal antibody. What's special about ofatumumab, it is a sub-Q injection that the patient can do. It's a self-injectable. It's a monthly injectable that can be given sub-Q once per month, while the other anti-CD20 monoclonal antibody that they are IV infusion that are given intravenously at the hospital every 6 months. Now, I listed for you a lot of medication and a lot of choices. How do we choose between all this drug? I will not answer you, but I will leave the floor to my colleague, Joelle, who will discuss with you the guidelines for MS therapy and how really we choose a specific drug for a specific patient. Thank you, and I will wait for the question in the panel discussion. Thank you.
Thank you so much, Maya, for this comprehensive wrap-up on all disease-modifying drugs in multiple sclerosis. It's always important to start with a lot of information because I think everyone is ready in the beginning and they can really concentrate with us. So let's keep this energy as we go through our sessions. And I'll move on to the next session that I will be giving. Let me share my screen. Okay, so I think you can all see my screen now.
Yes, 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 sure.
So next, we'll be discussing the MS treatment guidelines, and in terms of updates, in terms of how do we think about treatment guidelines now? Have we changed the way we think about how we treat MS? Did all the upcoming disease-modifying drugs and the changes in drugs change the way we think about treating this disease? Have we become more aggressive in treating MS? Did we learn from other disease areas like cancer, let's say, like rheumatoid arthritis? What changed? What are the latest updates that we got from all of the international conferences that we are attending and presenting at? And what is the research that we have contributed to or learned from as well? So you will see some slides that Maya have already shared. So I will probably skim through those quickly. But so these are my disclosures. And just like Maya was saying, so to pick up from where she really left off, how do we choose? How do we think about disease-modifying drugs? When we have those discussions with patients, and generally it might entail, more than one visit, but we have to think about efficacy versus safety versus tolerability as well. But we also have to always inform and allow our patients to make the informed decisions by giving them all the evidence. So by really supplying them with all the information, and also by educating all the healthcare professionals to be able to assist our patients in making all these proper choices, from nurses to pharmacists to doctors to everyone taking care of our MS patients. So, starting on with looking at whether having baseline MRI lesions in the beginning of the disease, does that really affect how we progress, how patients reach disability faster or not? Yes. So we're trying to really stratify patients and think about what is the right treatment to give to the right patient, right? So the first time we see our patient in clinic, we're trying to decide. Maya discussed all of these treatments. What is the right medication to give to this patient? How do we offer our patient the right treatment? Because we all know there is still not one blood test or biomarker we can do for our patients to discover what's the right treatment that will be working for them 20 years down the line. So we need some answers, some numbers, some guidelines that will help us. And this is what bodies like Minactrims have done by publishing guidelines, and international bodies and the guidelines we recently published in the UAE as well. So we look at all these data that help us really answer those questions, okay? So definitely having more baseline lesions, the greater that number is, the faster people reach a higher EDSS score. We also know that permanent axonal loss correlates with ongoing inflammation. And we know that we have to prevent further damage in MS, and this is best done as early as possible when the disease is active. So there's like a window of opportunity that we should not be losing. We need to act as early as possible. And what is lost by delaying treatment most of the times cannot be regained at a later stage. Early suppression of active inflammation may help to minimize cumulative axonal loss. And from here, we start to discuss new concepts that have emerged in the last few years, such as PIRA, which is progression independent of relapse activity. And we now understand that PIRA starts in the early stages of the disease, and it can occur independently of relapse early in the disease course, as I mentioned. And it's supported by a more diffuse process called smoldering MS that we now discuss and talk about. And this affects the entire central nervous system. There are many pathological drivers of PIRA that can be potentially modified by different therapeutic strategies. And that can have a lot of implications on the lives of people with MS. So even comorbidities can also affect the CNS and PIRA itself. And so this should be complemented by a holistic approach. And who better than nurses and other healthcare professionals to really complete this holistic approach that we need to provide to our patients to manage MS and all other systemic disease processes that can also worsen MS outcomes. So what we need to know is that there is a stage where we will be having patients developing all that inflammation and the active MS stage, where we might be building new lesions, new active relapses. And then this is the stage where probably there might be some sort of compensation, where not everything will be showing in terms of residual disability. Patients might be compensating at this stage, but we will reach a point of no return, or a point where the reserve threshold is reached, which is around here. And this is where, after that, we will start reaching the post-inflammatory neurodegeneration, and where people living with MS will hit the point of no return, if we want to call it, and where we will be starting to lose function and residual disability will accumulate. On top of that, we will be reaching the aging stage, and also that will be confluent as well with other things that are occurring too. So, studies have also shown that there's a difference between relapse-associated worsening, what we call RO, and you can see that there is worsening associated with relapses, and this is when patients do not really return back to baseline after relapses, and there is PIRA, which is independent of relapses itself. But what drives the composite disability or the confirmed disability progression is mostly PIRA. This is what we have noted, and this is what trials have concluded. A considerable proportion of this overall disability is driven by not relapses themselves or the relapse-associated worsening, but this progression that is occurring independent of relapses, and that has been occurring probably from the beginning, and that we are missing, because as we always say, and we kind of make that metaphor to patients, we have to think about MS as an iceberg. There are things, occurring above the surface, but most of what is happening is under the surface. So to be able to catch those things, we have to do proper assessments, and we really have to hit early on, high efficacy, and treat early on, so that we avoid that from happening. So when we think also about PIRA, we also challenge the current distinction that we really, or the old phenotypes that exist between thinking about relapsing remitting MS as a different and separate entity from progressive or SPMS and primary progressive MS, which have been the entities we really use to discuss or categorize MS. Now we think of these processes as kind of ongoing from the beginning, but at different extents, if we want to say. So studies have also looked at the effect of medications on these new concepts. Do medications suppress PIRA? Do they have an effect? And for example, the study of ofatumumab specifically looked at the effect of ofatumumab versus teriflunomide on delaying the time to first 6-month PIRA, and it showed that it significantly delayed that time when compared to an active comparator, which is teriflunomide, in all patients. Moving on, we have to also emphasize the point that earlier initiation of high efficacy therapy has a long-term effect on patients' disability progression. So comparing patients who started treatment early on, and that is defined here between 0 to 2 years of disease onset, versus patients who started treatment later, 4 to 6 years after disease onset, those who started earlier showed higher risks of disability progression, which makes us conclude more and more evidently and more confidently that we need to start treatment earlier. And this, I believe, was already shared by Maya as well. And it also goes on to prove to us that high efficacy therapy reduces the risk of RRMS converting to SPMS. Now, I think we did not discuss that before. So also what we need to think about as well when we're talking about the way we changed how we think about treating MS is also we changed our concepts of thinking whether RIS is a separate entity as well, and whether we need to treat RIS or not. And what is RIS really? And this is radiologically isolated syndrome. And it's when patients present with incidental findings on MRI, findings that are typical of MS in terms of lesion location, and they fulfill criteria for RIS, and there are criteria for that as well. The MRIs would have been done for any purpose, like headache or anything else, so incidental findings. And studies have been done to show what kind of risk factors or characteristics really increase the chance of transforming or developing a first clinical event or becoming MS. So these risk factors have been shown to be age less than 37 years, presence of positive oligoclonal bands in the CSF, presence of gadolinium-enhancing lesions, presence of intratentorial lesions, and presence of spinal cord lesions. All these are worse, if you want, prognostic factors. And so how do we stratify the risk for our patients? How do we divide our patients? Are they at risk of developing MS when they have any of those factors or not? And what has been shown is the more factors they have, the more risk, obviously, they have of converting into MS. So, of course, if they have up to 4 factors, they have a higher, almost 87% chance of converting into MS. And so some of the world-renowned experts on RIS, from Okuda to Lebrun, did trials to see what kind of medications we should be starting, or should we be starting medications for people living with RIS. And now, in the latest updated McDonald's criteria, which have been published, shared in the latest ECTRIMS like a month ago, we have gone on to start thinking that we don't really separate, and that RIS will probably be thought of as MS eventually. So trials have looked at 2 medications specifically, DMF, which is dimethyl fumarate, and Maya talked about that already, which is an oral medication given twice daily. And this trial by Okuda showed that it decreased the risk of a first demyelinating event by 82%, which is a remarkable opportunity to really extend the time to reach the seminal first demyelinating event. So we are changing again the natural history of MS, and not really of MS here, of even before reaching MS or becoming MS. And another study, as I said, by the second world-renowned RIS expert was a study on teriflunomide, which Maya already talked about, and this is a once daily oral medication given in MS, and it also was done compared to a placebo. It followed 89 patients over 2 years, and it also showed a significant risk reduction in developing a demyelinating event. So this all supports the idea of treating RIS patients when they fulfill certain criteria. So this takes us to the next step of what are the updates in the latest MENACTRIMS guidelines regarding RIS patients. And here we emphasize that those patients fulfilling the Okuda 2009 criteria should be referred to a specialized MS center to decide on a treatment plan, because as you can see, treating RIS is complex, and we have to really be very careful about which patients should be selected for treatment, how we should be following up these patients. And in the presence of multiple risk factors, such as the ones we looked at before, so more than one and multiple risk factors, and evidence of new lesions on follow-up, so we have to keep following up our patients. We don't just do one MRI and never see that patient again. We should be doing ongoing follow-ups with MRIs and other measures as well. Patients with RIS should be considered for treatment. Now, what about RRMS? Of course, Maya mentioned all the drugs and talked about most of them, about all the latest data on them. So just to skim through, of course, I will not mention data again, but just to talk about the highest efficacy medications with high efficacy. Of course, you've seen the data already, and how most of these medications really decrease the annualized relapse rate to a significant extent, as we can see with alemtuzumab, most of the monoclonal antibodies, natalizumab, and how it suppresses the ARR from the first year significantly. This is for B-cell depleting therapies, and we can see with ofatumumab the major decrease in the mean number of GAD-enhancing lesions, which almost became 0. So generally, we say when we see any new activity on these medications, honestly, we have to start questioning the diagnosis, right? We have to look at whether this is MS or not when we see really active patients on such medications. And honestly, when I think about my practice, now in the last few years compared to when we first started, and Maya, of course, can corroborate on that because we've been working together for so long. It's so different in terms of how our patients are managed now or react now or are stable now. We rarely see such fulminant relapses anymore, or for people who are, of course, well maintained. I know people come from different backgrounds or different countries, and access to treatments is different. But I'm talking about ideal situations, of course. And of course, there's our study from our center in Beirut, and also we can see the major suppression of the annualized relapse rate when people are put on rituximab as well. Which is also going to be mentioned, I'll show you in the treatment guidelines as an off-label use as well. So how do we balance efficacy and safety? There was always this notion that we always have to have we can accept efficacy, but at the price of safety. And this has really changed, not anymore. We do see still a lot of providers still very hesitant about starting high efficacy therapy from the beginning because of a fear of perceived safety concerns. But there's been published also studies about the difference between patients' willingness to accept risk and providers' willingness to accept risk. So if we ask patients, and that's why a lot of patients really ask about therapies such as stem cells and even unapproved therapies sometimes, and because patients sometimes are willing to accept risks, and because they are living with their disease. It's not us who are living with the disease. So we really have to understand that for patients, sometimes they are willing to accept risks in exchange for clinical efficacy. Priorities differ between providers and patients. But the good thing is nowadays with all our really high efficacious medications, they don't all come with a high price of safety, which is good and which really offers our patients a good treatment option. So new DMTs really provide a better safety efficacy balance and allow us to start early treatment with high efficacy DMTs with not significant safety concerns. Of course, everything has to be done with MS specialists, with proper monitoring, follow-up to really help our patients. Now, to discuss a few last concepts, when we want to think about which are the right patients to treat. And of course, we don't just start all our patients on high efficacy treatments. We still have to categorize our patients to a certain extent. So to think about that, of course, because when a patient presents to the clinic, to really help that physician or provider or clinician, we need to have guidelines, of course. And so that not each provider has to do all that thought process every time he is faced with an MS patient, or else they would probably stop seeing MS patients. Guidelines have done all that work, specialists have done all that work to try to put all that evidence and define entities. So they've looked at defining active RRMS versus aggressive RRMS, and to put those in categories and see which medications work best, or the evidence tells us they might be the best option to these categories. Of course, there's no current consensus worldwide, but there's expert opinion, and this is where the guidelines have helped a lot. So the following clinical and radiological features can be taken and should be taken into consideration when determining if a patient has high disease activity. What's the relapse frequency in the previous year? Is it 2 or more relapses? What's the relapse severity? Is it in the pyramidal cerebellar systems? Did the patient recover completely from the relapses? Do they have a high T2 lesion load, 10 or more lesions? Do they have spinal cord involvement, infratentorial lesions, active GAD-enhancing lesions? What about the other entity we call READ, or rapidly evolving aggressive RRMS? So this is a subgroup of patients with high disease activity that will follow a rapidly evolving course. And again, there's no clear definition, but based on the evidence, Minactrams has come up with the definition in the guidelines. Those are patients with 2 or more disabling relapses specifically with incomplete recovery in the previous year, so in the last year before presentation, and with a high T2 lesion load on MRI, which means 10 or more lesions. So these patients, they fulfill the criteria of rapidly evolving aggressive MS. Now, what about progressive MS? And Maya has already covered most of that. So she talked about ocrelizumab and how it decreased confirmed disability progression to a 24-25%. And we talked about the first drug as well, approved for SPMS. So both of these were firsts in the term of giving patients with progressive MS new disease-modifying treatments. Before that, we didn't really have much options, except if we want to say off-label medications. So these were the first on-label. And also, siponimod in its clinical trial showed risk reduction, significant risk reduction as compared to placebo in 3 months confirmed disability progression as well. So these drugs are the mainstay of treatment for progressive MS. And so for SPMS, active SPMS, we can consider treatment with ocrelizumab or siponimod for patients less than 60 and for EDSS 6.5 or less. For patients with PPMS, we can treat with ocrelizumab, of course, for certain criteria preferably, because these are the patients that were studied in the clinical trials. So particularly those with active disease, with age less than 55, also EDSS less than 6.5, and disease duration less than 10 to 15 years. Now, in patients with rapidly progressive SPMS, not responding to both medications, ocrelizumab or siponimod, or who have no access for one reason or another, off-label medications such as cyclophosphamide, chemotherapy, or methotrexate, or mycophenolate may be warranted in this case. To end, I will just remind you with the previous Minactrams algorithm for the treatment of RRMS and show you how it corresponds or looks when we compare it to the new Minactrams algorithm of 2023, where we have a lot more options to treat our patients with moderately active disease, highly active disease, and rapidly evolving aggressive disease as a first line. So we are definitely encouraged, and best practice shows us that we can start our patients with highly active disease and rapidly evolving disease on monoclonal antibodies from the beginning as a first line. And whenever we have any suboptimal response, we can switch in between class and go to other options when needed. For even suboptimal response, we can go to rescue therapy if needed with autologous hematopoietic stem cell transplantations or other options such as cyclophosphamide and mitoxantrone, which we reserve for very multiple failures when we don't have other treatment options because of their detrimental side effects. And with this, I will end, and I will hope to see some of you or maybe all of you in Jeddah next week for our 9th Minactrams Congress. Thank you for listening, and I would like to remind you that you can add your questions in the question box, and we're going to take the questions in the panel discussion at the end of the day today, at the end of our lectures. And next, I will invite Ms. Gina Lee to join us for her talk. Gina, are you with us?
Hi, yeah, I'm here. How are you?
Hi, Gina, how are you?
Good,
So
thank you.
I'd like to introduce you all to Gina. Gina is a registered nurse who has 12 years of experience working with neurology patients. She began her nursing career as a neuro ICU nurse in Canada before moving to the UAE. She then started as a neurology coordinator at Cleveland Clinic Abu Dhabi before becoming a multiple sclerosis nurse for the past 3 years. She's highly experienced in MS, and she's joining us today right here from Abu Dhabi to talk to us about the art of counseling people living with MS. So I'll leave the floor to you, Gina. Thank you.
Thank you. Thank you, IVPN and Novartis, for inviting me to speak today. Let me just share my screen.
Sure.
So someone else is sharing right now.
I think you can
Replace. There we go. Yeah. Can everyone see my screen?
Yes. Just
Okay.
you can put it in full
Slideshow mode. We're all good? Everyone can see? All right. So today I'll be talking to you about the art of counseling people with MS. So we've had two very thorough sessions about MS and the medications and how we treat and what MS is. I'm going to be going through the topics of how we treat people with MS. How do we talk to them? How do we engage with them? And how do we build relationships with them? So I'm going to be starting off with the factors that impact patient decisions and their understanding of MS. So people with MS having good understandings of MS and providers recognizing their needs, values, and preferences do foster mutually beneficial decision-making. So we as MS providers have all the knowledge about MS, what it is, what to expect, the medications and everything, but we need to be able to utilize that information and transfer it to our patients, but also understanding that their needs and their values all differ depending on each different patient. So we need to tailor how we treat our patients based on what they prefer. However, when we are unable to communicate our information to our patients effectively, it often leads to information asymmetry. And this means when healthcare providers possess more information than the people with MS and their supporters as well. So this generally leads to a lack of clarity around their health care terms, what MS is, what to expect, and generally their knowledge is quite low among the MS population. This is all because they have less information and understanding of what MS is versus the providers that have it. This occurs generally at the time when patients are diagnosed and also when they're discussing their long-term prognosis. The study out of Argentina showed that more than 70% of patients did want to know their long-term prognosis at diagnosis, but 21.5% never really discussed it with their healthcare team. And 47.1% actually lacked clarity about their MS, what it means, where they were, what type of medications, and that sort of thing. So just going back for a second. So going back into all the information that we learned in the first two sessions, we as healthcare providers need to be able to disseminate this information to our patients in a way that they can understand. So we have all the knowledge in the world, but if we're not able to disseminate it and break it down into a manner that our patients can easily understand, then it really is of no use. So we need to be able to understand that each individual patient has different education levels, a way of understanding things, and being able to tailor that to each individual patient. So when we don't provide enough information to our patients and explain it into a way that they understand, they generally do go online. And they do go online because they like to be prepared for their visits, or after their visits, they didn't quite understand everything that was being told to them, nor was it explained effectively. So patients generally went online 20 times per year, and this is actually twice the average of patients with chronic illnesses. So MS patients actually went online 20 times more per year, which is staggering. So with MS specialists, providers, nurses, pharmacists, there's no need for patients to be able to seek that information online. Yes, they can use that information to augment their learning and understanding, but the bulk of their information really should come from us and reputable sources. So generally the reason why our patients went online is, like I said, to do background research and do general information about their condition. So they were curious as to what MS is. They were figuring out basically what it is, what type of disease that they have now and what to expect from it. But they also did go online to be able to look up their physician prior to their appointment. So how much experience their patients or physician had, what type of neurology they were doing, are they reputable, which country do they come from. but we also did go online to find MS specialists and also support groups. More importantly, what they did go online for is to be able to find information prior to their appointment, because they felt that the time allotted to them for their visits was insufficient. So in order to effectively use their time during the appointments, they were gathering all the information that they needed, writing down all the questions so that they didn't waste any of the time during their medical visits. So now that there's more and more accessibility online to get information, it changes how our patients perceive MS and how they want their treatment. So generally, social media, when they go online, social media generally forms MS in a certain way. So not all sources are reputable. So as we know, our patients come in and say, oh, I Googled this, or I saw this on TikTok, or I saw this on Facebook, but not all information is reputable nor accurate. So we need to be able to understand where they have gone online, what they have looked up, and basically what sources they're viewing. And how we can do this is asking them directly, did you Google this? Dr. Google now is huge with everyone. Everyone is Googling all the information. That is fine, but they need to be able to understand that not everything is correct. So it's up to us to address this at each appointment, that did you go online? What type of information did you find? And kind of weed out the right information from the wrong information. Another issue that affects our patients' understanding of MS and how they make their decisions is basically poor communication. Communication still remains a significant issue in the MS population. The reason for that is basically there's just not enough time. There are short visits with a physician, there's an increased patient load, so there's more and more patients, but less and less providers to manage the caseload. Generally, we have poor communication skills or a lack of understanding what our patients need. And when we poorly communicate to our patients, this leads to the patients not understanding their MSs effectively, or wanting to trust us with the information that we do provide them, essentially. So what I do know is that when every patient that I encounter, they do want us to be open and honest with them. They want us to be kind and listen to them. They want to be treated with compassion. They want patience. They don't want to know that while I'm talking to them, there's 5 other patients that are looking to speak to me. I need to be able to ensure them that I am focused on them. I'm giving them the most focused attention and to be able to answer all their needs. Sorry. So poor communication, once again, from healthcare workers can result in substantial distress and even trauma-like reactions. So it's up to us to be able to communicate effectively with our patients to avoid this. We as healthcare providers have a huge role to play in how our patients understand things. And if we can't appropriately or effectively communicate to our patients, then we have failed them, because we have all the knowledge about MS. We know the medications, we know what MS is, we know the progress of it, but our patients need to be able to understand that information in an easy way. So I'm going to go on to what is missing for our people with MS. They need to be empowered. So empowering patients through education and sharing the decision-making process are the initial pathways towards disease acceptance and treatment adherence. We need to be able to empower our patients to be involved in their care. If they are involved in their care, then this leads to, medication adherence, coming to their appointments on time, better compliance with going to their MRIs, doing blood tests, and just coming to us when they have issues. And it also leads with greater satisfaction with the healthcare providers, which translates into an increase in the quality adjusted life years experienced by the MS patients. When the quality of life of our patients improve, we've done our jobs. So we want our patients to be able to successfully manage their disease MS. So I usually generally like to say we are their knowledge at the beginning of their MS journey. So first year, this is the toughest patients go through. We are their knowledge, we are their experience, we are their champion. But we need to be able to translate that into our patients being the champion of their own disease and being able to understand MS and being able to just manage their own disease and understand it completely. So the relationship with their healthcare providers to how well a patient adheres to the treatment, like I said, we need to have our patients trust us and support that they can be the champion of their own disease. If they don't trust us, if they have a poor relationship with us as a healthcare provider, they're not likely to listen to us. They're just going to do what they generally do and shop for different healthcare providers, which is completely fine. But someone needs to be that person for them that they're able to trust and understand that we want the best for them. And by doing so, we need to better communicate with our patients in order for this to happen. And what is also missing for our people with MS is being able to access a specialist MS nurse. So not all neurology facilities that manage MS have a specialist MS nurse. This is problematic because there does need to be a specialized person that a person can turn to when they do have questions, concerns, and issues. We do know that physicians' times are limited, so they may not be able to address all their issues when the patient needs to be spoken to. So they want someone that they can be able to contact in an easy access way. Rather than sending a message to a physician and waiting a few days for an answer, or calling the contact center and having them try to send a message to the physician and getting nothing in return. So they need to be able to access a specialist MS nurse. However, even when they did have access to specialist MS nurse, they didn't turn to them because they didn't quite understand what the role meant. They didn't know that a specialist MS nurse is there for them for many different reasons. They felt that the MS nurse was only there for medical problems and treatment queries, so that if anything else came into question, they wouldn't be able to ask us. They wouldn't come to us because they felt like that wasn't what our role was. So we need to be able to better advise our patients what our role is as an MS nurse, and being able to let them know that we're able to help them for this, this, and this. And even if we can't help them, we can still guide them in directions where they can find help or assistance or their query to be answered. And most importantly, like not being able to access a physician, they didn't turn to an MS specialist nurse because we were unresponsive. So this goes into play that we need a better method of having our patients contact us, that whether that be email, through phone, through nurse visit sessions, just being able to have them access us. Because when they are in a crisis, when they feel like they're going through a relapse, they do want an MS specialist nurse that they can reach out to just feel reassured that what they're going through is in fact not a relapse, it's a pseudo relapse, or they're going through a tough time in their life and they just want someone to talk to. So being unresponsive is one of the reasons why the patients did not turn to their MS nurse. Moreover, they often felt that the MS nurse, again, like I said, was treatment focused, that if they didn't want to start medication, that we wanted nothing to do with them. That, you know, if they have MS and they've been diagnosed, that if they don't start in DMT, we didn't want to hear from them, but that's not the case. Yes, we do want to encourage our patients to start a DMT earlier in the disease course than later, but we still need to guide them through the process of, you know, if they don't start a DMT, talking to them on a continuous time so that eventually maybe they will decide to start medication. But that's what we're there for, getting them to understand, talking to them, going through their concerns, helping them, basically supporting them in how they need to be supported. And moreover, lack of psychological support. We do refer our patients to psychology and psychiatry when they are diagnosed and when they do need it. But oftentimes, being a specialist MS nurse, we can be that psychological support as well. Oftentimes, I do hear it from my patients that just speaking to me, just being there, just talking to them on their phone, guiding them through a tough time in their life is enough and supportive enough, and they really do appreciate that. So I think we need to be able to, yes, use all the knowledge we have about MS, but being able to support them in a psychological way, whether it's, you know, just something simple that they've had a tough day or they're going through something difficult at work, just being there to support them at that time. What else is missing for people with MS? Research has shown that people with MS have a lack of knowledge about the disease, and the information is not presented in a clear and appropriate way. Care providers lack the ability to explain complex information, and we need to understand that individual priorities of people with MS vary. There's not a one-size-fits-all approach for our patients. So this is the same kind of story going through. Patients need to be communicated in an effective way. They need to be able to understand the information that they're receiving. They need to be able to know what MS is in a term that they understand. And most importantly, there needs to be more time in consultation for appointments. So MS is a very complex illness. It's not just a one visit, you start medication and it's done. Patients will continuously have questions, continuously have queries, want to know about things, need to discuss a relapse that's happening. And there just needs to be more and more time allocated for our patients. But unfortunately, appointments are limited. And this is hopefully why the MS nurse role is important, so that we can spend the time with our patients and be a bit more, involved in their care. So as I've been discussing in the previous slides, communication. Communication is very key for our patients. So I'm going to be going through a little bit more of how we can better communicate with our patients. When we're in a visit with our patients, communication means exchanging of information. We need to respond to their emotions and help manage and build relationships while making decisions. So basically, we need to essentially be able to read the room. When we're newly diagnosing our patients, we give them tons of information. What is MS? What is relapsing remitting MS? What does a relapse mean? What is lesion load on an MRI? What are medications? It's a lot of information being provided to our patients. So we need to be able to understand that emotionally, they may not be able to receive all this information at one time. So I generally do break up the visits. They've had enough for one day. Let me call them in a few days to see how they're feeling. Will they have more questions at that point? Yes, they most definitely will. I generally do advise them to, just write things down, jot the questions down as they remember them. Because when you do call them or see them for a nurse visit, they may not remember everything that they're dying to ask. So that's being able to build a relationship with them where they feel open to talking to you and feeling like they're not disturbing you, so that you have all the time for them, even though you may not. So that's important to build the rapport and building trust for our patients. But this also enables us to have satisfied patients, as well as motivating our patients to work together with us. So we want them to be able to believe what we're saying, trust what we're saying, and that what we're trying to do is in their best interest, rather than, oh, you're an MS patient, we just want to put you on medication and we're going to put you on this one because this is what we feel is best for you. No, it's working together so that patients can understand what their MS diagnosis is and the type of treatment that is important for them to start, and why we're choosing to start that, and what they need to be able to do throughout their disease progress. So we want to be able to listen with the goal of understanding. So we listen to our patients, we hear what they are trying to say, and we try to understand. So what that just means is that while we're listening to them, we're not thinking of the answer already that our patients want. So we want to be able to focus on what they're asking and be able to let them vent and also hear them out. Oftentimes they're not here for us to be able to give them the solutions. They just want us to listen to them. So generally feel out the situation. Do they want advice, or do they want us to just listen to them and hear them and just understand what they're going through, to be able to be that emotional support for them? In some ways that you can do it through effective communication is to be able to do some active listening skills. And the first one is nonverbal. What that would mean is eye contact, open body language, nodding or just acknowledging that we're listening to them, as well as paraphrasing, summarizing, and restating what they've told us. So it's not providing new information, but just restating, summarizing what they've told to us so that they know that we're listening to them and that they are being heard. Minimal encouragers like go on, things like that. And also reflecting feeling and reflecting the content. So, showing your emotions and showing that you're listening to them and that you do feel and understand what they're saying. They want to be able to know that they're talking to someone rather than talking to a wall. So they want an engaged person. So going into that, anxiety, depression, and stress is huge for MS patients, as we know. So I'm going to go into a little bit of that and how the anxiety, depression, and stress affects our patients and how we can help them through this. So due to the nature of MS being unpredictable and incurable, it is usual for people with MS to go through psychological distress, diagnosis, and along their MS journey. commonly exhibited in the forms of anxiety, depression, stress, negative affect, and sometimes with symptoms of trauma. It's important for people with MS to receive the appropriate psychological support to deal with these psychological difficulties, and that is psychiatry and psychology. We always say it's important to at least see a psychiatrist or psychologist one time. If we're not saying that, you have a mental issue that you need to, or a psychological diagnosis that you need to be seeing someone for, but you are receiving a new diagnosis that your life is going to be changed and different. So it would be good to be seeing an impartial person for you to be able to discuss with them and talk to them on different techniques to cope for a new diagnosis. So people with MS receive insufficient emotional support at the time of diagnosis. This is true, especially with our Middle Eastern population. A lot of them do not want to seek psychiatry or psychology referrals simply because they don't want to be. This is not something that's accepted, nor do they want to be deemed as crazy. We need to emphasize that that's not what you are. You're not crazy, because that's what a lot of our patients tend to think when we try to refer them. But like I said, you're going through a tough time with the new MS diagnosis. It would be good to seek help professionally so that they can guide you through the new diagnosis and be able to have the tools needed in order to overcome this new life, basically. So how can we as healthcare providers help? And that's basically what I've been just saying, is just trying to let our patients know that it's okay and normal to have feelings about MS. It's okay to be emotional. It's okay to be stressed. It's okay to have feelings about MS. Just letting them know that you're going to have days that you're doing well and the days that you're not doing great. But that someone is here to help you through that. So we need to be able to acknowledge emotions. Almost all persons with MS report some sadness, worry, or stress related to their diagnosis or the impact of their disease on their life. These are normal reactions. Some short-term reactions reactions to the diagnosis, such as anger, fear, shock, grief, relief, or even denial. These are the general reactions that people have for new diagnosis or a new change in their life. Some long-term reactions could be grief, anxiety, anger, guilt, and depression. And these may be reactions to the symptoms of MS and to the life changes caused by the disease or the uncertainty of MS. And also there's medications as well that can affect the mood. So emotional changes can be part of the disease itself. 50% reported depression while having MS, and 35% had anxiety. Living with a chronic unpredictable disease can be anxiety provoking, and many persons with MS do report worries about the disease and worries about how the disease will impact their lives. So why is it important to treat depression and anxiety? Treating depression can improve MS-related fatigue and also cognitive functioning. It affects their quality of life and, again, causes depression, anxiety, stress, and it's all related to lower health-related quality of life. And depression is the most important predictor of quality of life after controlling for disease severity. It also causes social anxiety. Our patients generally have lower social activity due to the increased levels of stress and anxiety, and basically don't really want to go out with their friends or family anymore or engage in social activity because they feel that their MS disabilities is hindering their friends and their family, and that they don't want to show that they have an illness. But it's important for their patients to overcome the stress and anxiety and get family and friends involved. So some stress and relaxation tips would be just to be able to monitor the stress and actively work to decrease the stress. So stress is associated with lower quality of life in MS patients. And how do we fix that stress? How do we resolve that stress? Basically, take a self-inventory. What do you do in your daily life that you do to decrease your stress, sorry. What works for it, what doesn't work, and basically what do you need to change? Stress and relaxation for the stress is different for every person. So each person needs to identify what works for them, whether it's going for a walk, meditating, doing yoga, working out, reading a book. Everything is different for each person. So I always say, find something that you find helpful for yourself when dealing with stress. Just basically, what do you like to do? And utilize that to decrease the stress. And also, seeking support from not only family and friends and professional support, obviously, but letting friends and family know, letting someone in at least to know that you have MS would be helpful, so that they can support them along their disease trajectory. And most important, while knowing that some stressors are not changeable, you can control the response to the stressor. So basically, not everything can be changed, but how you encounter stress, how you think about stress, how you deal with stress can be controlled and changed by each person. So what I would just like to say is that we need to be able to recognize the negative connotations or beliefs about MS. We need to be able to catch those negative thoughts and being able to change them. So generally, using the 3 C's, catch it, check it, challenge it, or change it, would help our patients turn those negative behaviors into positives. So when you catch it, you're actively thinking about the negative thoughts that are going on in your head. And then when you do realize you're thinking negatively, you check it. Are you actually thinking of it in a negative way? Take a step back and see what other ways you can view it. And by doing that, you're going to challenge that negative thought and look at it differently and change it. How can you think of the situation as a bit more positive? So acceptance of MS is associated with better personal and marital adjustment, lower stress, distress, and higher positive affect, life satisfaction, and quality of life. So it's possible to change emotions by challenging and changing unhealthy thinking patterns. I think my time is up, but I'm also done as well. So I just want you to remember that healthcare providers can play a large role in counseling people with MS through listening to patients talk and answering questions. Again, we have all the information about MS, but it's how we're able to break it down to our patients so that they can easily understand it is key. Building relationships, fostering a good understanding with our patients and knowing what their needs are would be beneficial. And once again, thank you for inviting me to talk today, IVPN and Novartis, and thank you for everyone for logging in.
Thank you so much, Gina, for your talk. I'm sure all our attendees really learned a lot from the skills you provided them with. So we're gonna learn a lot more from you and during the panel discussion, because we already have some questions lined up. So stay with us, please.
Will
Okay.
do.
Thank you. We're
Thank
gonna
you.
start with our last speaker of the day. I'd like to welcome Dr. Muna Thakre to join us for the last talk. Again, thank you, Dr. Muna, for staying with us till the end. So, of course, Dr. Muna is also a very well-known, experienced neurologist. Dr. Muna has more than 20 years of experience right here in the UAE and in India, where she originally earned her MD degree. She went on also to specialize in neurology from the Royal College of Physicians in the UK, and she's also a fellow of the American Academy of Neurology. She worked in several hospitals in UAE, including Rashid Hospital in Dubai. She went on to head the neuroscience department at Al Zahra Hospital in Dubai. She's elected as a board member of the Emirates Neurology Society. Of course, her areas of interest include multiple sclerosis, headache, stroke, epilepsy, and movement disorders, among many others. She's an active researcher and has had multiple presentations in local and international conferences. She's also published multiple research in numerous peer-reviewed journals. Thank you, Dr. Muna, for joining us tonight. And you'll be talking to us about B-cell depleting therapies for RRMS, their safety, efficacy, and counseling us also on practical clinical tips. So please, the floor is yours.
Thank you so much, Joel, and thank you, Novartis and IVPN, for the invitation. I know you've heard a lot about drugs, but now I'm going to do a deep dive into the CD20s only. So hopefully, can I share my slides?
Yes, please, go ahead.
So I hope the slides are clear.
Yes, they are.
So I'll be discussing the role of B cells and the anti-CD20 therapies in MS pathology. So let's start with a very, very basic thing. What are B cells? Okay, so let's go back to our, the first years of our school. and know what B cells are. So it starts with the blood stem cell. So we have two lines. We have a myeloid stem cell line and a lymphoid stem cell line. The myeloids will give you the RBCs, you will get the platelets from them, and then you have the myeloblasts, which gives you the granulocytes, eosinophils, neutrophils, basophils, which are part of the white cells. And then you have the lymphoid stem cells, which give you the lymphoblasts, and they form the B cells, T cells, the natural killer cells. So both the lymphocytes and the neutrophils with the eosinophils, basophils form what we call the white blood cells. Now, of those, the B cells, what are they for? So they have many inflammatory and regulatory immune systems. So what are the inflammatory functions of the B cells? So they form what we call the antigen presentation. So if there is an infection, the B cells come into play and they present the antigen. Okay, they form the antigen transport. They secrete the pro-inflammatory cytokines. They give you the immunoglobulins as well. They also have regulatory functions. So they secrete what we call IL-10, IL-35, which stimulate the T regulatory cells. They also stimulate the Th1, Th17 cells, and they secrete the regulatory immunoglobulins and the neutrophic factors. So a lot of functions for the B cells. So in a nutshell, this is a diagrammatic way to explain the functions of the B cells. As I explained, it is antigen presentation. So it presents resulting in it presents the antigen resulting in clonal expansion of the cytotoxic T cells and cytokine production. Then it produces the cytokines, which also stimulate the macrophages, which in turn releases the cytokines and TNF, IL-6 and IL-1. They are involved in antibody production, and they also form what we call ectopic lymphoid structures, which I'll be going into. So why are we speaking about B cells, and what is the relationship of B cells, and is there a proof of their role in MS? So we have a lot of proof of these cells being active in MS pathology. So now we have proof that we have the role of Epstein-Barr viruses, which actually reside into the B cells. Then we have the evidence that this B cells secrete the oligoclonal bands, which are seen in the relapsing remitting CIS and SPMS up to 95% of patients. And when we reduce the B cells, we have proof that it reduces the number of relapses in our MS patients. And then now we have proof that in the SPMS patients, we have these aggregates of B cells inside the lymphocytes, inside the meninges. And this is how they look. So these are B cell infiltrations, which are seen into the follicles in the meninges. And these are mostly seen when the patient goes into a secondary progressive MS phase. So now when we know about the B cells, what is this CD20 doing? Okay, now what is the CD20? CD20 is an amino acid which sits on the surface of the B cells. Okay, and this is involved into complement-dependent cytotoxicity, antibody-dependent cytotoxicity, and complement-enhanced antibody-dependent cytotoxicity. So this CD20 molecule is co-expressed on the B cells with CD19 as well. So it has a very important role to play in this cytotoxicity. So what happens when we have this CD20 mediated depletion? So we will be involving all these cell lines of the B cells from the pre-B cells to the late lymphoblast cells. And we have a number of chemicals or compounds which are actually acting on these. So we have initially the rituximab or ocrelizumab, and now we have the ofatumumab, which affect this CD20 molecule. So what does it do? It rapidly and profoundly depletes the circulating CD20 positive B cells. But what it spares is the stem cells, the pro-B cells, many plasmablasts, and the terminally differentiated antibody-producing plasma cells. So it's not killing everything. It is still sparing the stem cells. And there is unclear evidence if the rituximab, whether when we give the rituximab inside the CSF, does it affect the B cells or not? We are still not sure. But when we give the IV rituximab or B cells anti-CD20 chemicals or compounds, they do deplete the B cell population. So let's go into the evolution of anti-CD20 monoclonal antibodies. So it started with the murine, which is the monkey-derived or mouse-derived sequences. And rituximab has a mixture of that. So it has the chimeric and it has a bit of the humanized protein. Then we have the ocrelizumab, which is humanized, which has few sequences of the murine. And then we have ofatumumab, the latest kid in the block, which is fully human antibody, CD20. So this is how it looks. This is the rituximab, which is an off-label molecule, which is still used into MS, but it is now included into the essential WHO list. So if the patient is not getting approved or cannot afford ocrelizumab or ofatumumab, we can still give rituximab and it works extremely well. Then we have the ocrelizumab and the ofatumumab, which are present. So this is the way these molecules are there. So we have another one, it is called the oplutuzumab, which is still not available in the Middle East. We have the old rituximab, which is there and still available for use. The dosing is about 500 to 2000 every 6 months. Then we have the ocrelizumab, which is the humanized one, also known as Ocrevus, which we give 300 milligrams day 1 and day 15, and then 600 milligrams every 6 months. And the latest and the fully human ofatumumab, which is given subcutaneously monthly. And this is the comparison of the half-life of these anti-CD20s. So ofatumumab clears out between 12 weeks, ocrelizumab 18 weeks, and rituximab 16 weeks. And this is important when you're considering this patient for pregnancy, and these half-lives will come into importance. So let's see these different anti-CD20s. So the label of the anti-CD20 for ofatumumab is all relapsing remitting MS, for ocrelizumab, relapsing remitting and primary progressive MS and SPMS with activity, and rituximab, though not approved, it is still in the essential WHO list and is used for relapsing remitting multiple sclerosis. Now, how do we actually differentiate, and where do these molecules actually attach on the CD20 molecule? So they actually attach in different parts of the CD20 molecule in different parts, but the end result is depletion of the CD20 cells. And the way it depletes is there is complement-dependent cytotoxicity, antibody-dependent cytotoxicity, and direct cell lysis. And as I said, ofatumumab is given every 4 weeks subcutaneous. Ocrelizumab is given every 6 months, and initially 2 doses, day 1 and day 15. And rituximab is given 1000 milligrams every 6 months. You don't need any pre-medication for ofatumumab as it is fully humanized. Ocrelizumab needs pre-medication, and rituximab also needs pre-medication. Safety for ofatumumab, there are no boxed major warnings. Ocrelizumab, of course, there can be some injection site reactions. So you need to pre-medicate these patients, and there is increased risk of infections. And we'll be going into that. Now, if you compare ofatumumab and ocrelizumab, you can see from the network meta-analysis that there's not much difference between the two. So this is in short the differences between the 3 molecules, rituximab, ocrelizumab, and ofatumumab, as we have mentioned. So let's speak about ofatumumab, which is the latest drug in the market. It has been there for last 6 years now, and we have a long-term safety data of ofatumumab now with relapsing remitting multiple sclerosis. And this was the initial preliminary phase 3 trials, the Asclepius 1, and Asclepius 2. And you can see a big difference between the active comparator, which was teriflunomide, with ofatumumab. And as the years go by, you can see that the annualized relapsing rate was very, very low, and 9 out of 10 patients were free of any disease activity, which is called NIDA-3 in the continuous and in the switch groups. A sustained low annualized relapse rate was observed in patients receiving ofatumumab up to 6 years. And you can see a big jump from the people who converted from teriflunomide to ofatumumab, and also from ofatumumab who continued into the open label extension, also continued to have progressive benefit of the effect of the medication. GAD enhancing lesions almost became zero. This is 97.7% reduction of the GAD enhancing lesions, and this was even continued during the extension phase. Earlier, ofatumumab treatment was associated with lower number of sustained disability worsening events up to 6 years. And as we all know that the earlier you start high efficacy medications, the better they do. Safety profile remained consistent with up to 6 years of treatment, and there were no safety or unexpected safety signals, and there was no increase in malignancy in the 6 years follow-up. The incidence of serious infections remained stable and did not increase with ofatumumab up to 6 years, and the discontinuation rate was very, very low. There were only 6 cases of fatal cases in COVID-19, but otherwise, most serious infections actually fully recovered. The other concern about anti-CD20s is you have a reduction in the immunoglobulins. And with ofatumumab, the mean IgG levels remain stable up to 6 years, and the mean IgM decreased, but it remained above the lower limit of normal. So in conclusion, at year 6, 9 out of 10 patients were free of disease activity, NIDA-3, in both continuous and switch groups. And participants who were initially treated with teriflunomide had greatly significantly lower rates of NIDA-3, but these rates rapidly increased after switching to ofatumumab. And continuous ofatumumab treatment had fewer confirmed disability worsening, and earlier initiation of ofatumumab was always beneficial. There's a consistently safety profile over the 6 years, no serious adverse events, and the IgG levels remained stable. Let's go through some practical considerations before and during starting the anti-CD20. So whenever we are considering a patient for anti-CD20, you need to have a screening before starting these therapies. And the screening tests involved the hepatitis B, surface antibody, core antibody, surface antibody, and if these are the antibodies are negative, you should consider vaccination, hepatitis B screens, lymphocyte count, HIV, immunoglobulin level, varicella zoster IgG, TB screening, and you need to see if the quantiferon test is positive or not. So these screening tests are extremely important, and we need to see that they are immunized before we start these patients on anti-CD20. So both rituximab and ocrelizumab have infusion site reactions, and we do need pre-medications. And pre-medications is treating with methylprednisolone, acetaminophen, and diphenhydramine. If we do see some symptoms of urticaria, or it is managed with IV fluids and slowing down the infusion, or sometimes pausing the infusion, you can retreat with steroids and diphenhydramine or acetaminophen. But if it is shock or anaphylaxis, which is extremely rare, you need to discontinue and start appropriate treatment. Real life experience actually suggests that the severe reactions with subcutaneous injections with ofatumumab is extremely rare. And our experience is that you hardly get any reactions with ofatumumab. First, second injections, you might feel some feverish or fluish symptoms. You just need to take paracetamol or ibuprofen. Rare mild infections could be there, but increased risk of severe infections has not been seen with ocrelizumab or ofatumumab. And PML some cases of PML have been seen with rituximab, and some carryover from ocrelizumab from natalizumab have been observed. But we still, it is just needs to have an appropriate vigilance. But it's still now, we do not recommend JC virus testing for these patients. Now, breast cancer was seen among slightly higher incidence in ocrelizumab, but the long-term data did not suggest that there was any indication or signal for breast cancers. So the FDA recommends that we just counsel all patients and maintain an age-appropriate cancer screening for these patients. And as far as rituximab and ofatumumab are concerned, there's no increased breast cancer risk as seen. And as a class, these are considered highest efficacy medications, and they are very well tolerated. But there can be increased incidence of infections, and sometimes a minority of people can have hypogammaglobulinemia. So we need to keep an eye on these levels and keep checking these levels, especially after the 3rd and the 4th year. Optimum dose and duration has been a thought of contemplation, and COVID-19, we did extend these intervals of especially ocrelizumab infusions, but this is still under study. And with that, I'd like to thank you for your attention, and I'll be happy to answer any questions.
All right. Thank you so much, Dr. Mona. I believe we are right on time. So I would like to thank you all. Thank you, Dr. Mona, and thank you to all our speakers, Ms. Gina, Dr. Maya, for all staying with us till the end. So we have a few questions. We have a lot, actually, so I'm going to summarize and just take a few questions so that in the interest of time. So let me start with Maya. So Maya, in terms of medications, what are the medications that are in the pipeline now? Are there medications that are also new and we haven't discussed? And what about remyelination treatment strategies?
So, of course, the chronogram I showed in the beginning of my slide showed that there are a lot of medication in the pipeline, and the most now class that we have we have been waiting in MS is the BTK inhibitor. And in the past months, during the last ACTRIMS meeting, they presented some data about the efficacy of BTK inhibitors for the treatment of MS. So some of the BTK inhibitor, unfortunately, they failed to have any efficacy in relapsing remitting MS. Other, they showed some efficacy in progressive MS, and we are waiting more data from clinical trial about the efficacy and safety of BTK inhibitor in the treatment of MS. Also, we have a lot of molecules that have been tested for as remyelinating drug. We have a lot of some drugs that are used for other indications like antihistamines, anti-epileptic, anticonvulsant, that are being tested for as remyelinating drug, as well as other molecule being tested for this. So now all the research is if you want, all the research, upcoming research is focusing on finding this remyelinating drug that is able to remyelinate this myelin sheath lost and damage in MS. Hopefully, we'll have some promising drug in the upcoming years.
Okay, and just to follow up on that from some of the questions, where are we in terms of personalizing care and in terms of selecting some biomarkers that can assist us in selecting the right treatment for the right patient? Do we have some of those in our practice that we can use right now?
So in clinical practice, until today, we are not using biomarker and the neurofilaments for moving to personalized medicine. So we have some clinical parameter. Now we are more comfortable in selecting a specific treatment or DMT for a patient. So we are in a better position than years ago because we know more about DMTs, we know more about the risk, we know more about their efficacy, their long-term safety and efficacy. So we know better based on some clinical and parameters and prognostic factors to choose a therapy that will most likely will work on a specific patient. However, of course, this is not all. We need biomarkers that will allow us to select and to personalize treatment to patient. And those we have found many biomarkers, and during ACTRIMS they also presented on many biomarkers that were associated with treatment response. However, until today they are still used in the setting of research and clinical research, and until today we don't have yet any biomarker that we use in clinical practice. And I think Dr. Muna, this is what do I know, and she can also comment if she has any additional thing to do to say here.
Would like to add, Dr. Mona, anything to that?
Yeah, so I would agree completely. So at the moment we depend on the most common and the best used biomarker, which is the MRI findings. Okay,
Yeah.
if your MRI has a bad prognostic indicators, you have spinal cord lesions, you have a heavy lesion load, you have brainstem lesions, you have a bad prognostic factors. So these patients, we will be highly aggressive. We use high efficacy medications right from the beginning. Or if the patient is not willing, we will be looking out for the earliest switch if the patient fails the first line therapy, which is actually not happening anymore because we are straight away going into high efficacy medications. The other biomarkers like oligoclonal bands, the VEP, the retinal layer thinning, all these do help us. But I think the best biomarker which we have at this moment is the MRI.
Okay, great. Let me move on to Miss Gina. So Gina, what would you say are some of the prophylactic measures for MS? They're asking us about probably risk factors, they mean, or prophylactic measures you would probably communicate to your patients, or even maybe if they ask about their family members, what can be some of the prophylactic measures they can use to avoid having MS or getting MS?
Well, we would generally just say just the basic risk factors. So having a healthy lifestyle, which means, having a healthy diet. And that's not just adhering to a specific diet, but just generally eating healthy, because all of our patients Google the, best diets for MS, what will prevent you from having MS, prevent you from having new lesions. And there really isn't. Just eat healthy, have a good lifestyle, being active, not smoking, ensuring your vitamin D levels are optimal. All of those factors will contribute to you to having a good trajectory for your MS, hopefully over time. What is good for a healthy person is good for you as well. So that's just what we generally do say. But unfortunately, you can't avoid MS occurring. We all know that there's no cure and there's no change of one's immune system. So I think that's important for our patients to understand that it's not something that you can erase over time.
Yes. What about in terms of like physiotherapy and protocols? What kind of recommendations do you give to your patients, and how do you advise them on that?
I think it's always good to early refer to physical therapy and occupational therapy. They may not have a visible physical deficit, but it's good to touch base with a physical therapist so that they do know what type of exercise they can engage in and what they can do, because they may not have a genuine weakness, but it could be just from bending down to lifting up grocery bags to, holding their baby. So little things that do affect their day-to-day activities, but they don't really realize because they don't have a genuine weakness where they can't walk or use their arms and things like that. So we always say early referral to physical therapy is good, and referring when they do have a relapse and is clinically indicated is important as well.
Yes, exactly. And these are some of the things that we need to always be asking our patients about, and some of the actual patient-reported outcomes that we need to be getting from our patients. So information that is very valuable that we get from our patients during every visit, and that we can act upon in terms of action or intervention. So yes, thank you.
I'd like to add about fatigue. Sometimes we do need to tell them how to manage their fatigue. And I think the physio can also help in that. And because they have a pocket of energy, how to use that pocket of energy in the best possible way, split it up, use it in the mornings, evenings, keep the hardest tasks in the mornings, keep breaks. So I think these things also do help.
Of course, they help. They're essential, definitely. So Dr. Muna, some questions for you as well in terms of specifically like around the B-cell depleting therapies. So what would be your like preferred choice, or how would you counsel your patients that want to start B-cell depleting therapies and are women who are planning to get pregnant? How would you do that discussion with them?
Yeah, so that's a whole topic which we need another, clinic hour for that. But that's the most important one, and I think we should never ever miss that conversation with our patients, because most of these patients are in that group. Some people are, yet to be married. Some are married and are yet to have babies, and some people are married, having babies, and still want more babies. So the first thing important is to have a control in your multiple sclerosis situation. So once they have a good control of your MS, at least for a year, and there are no relapses, we can start planning pregnancy. And now with the B cell therapies, we know that you can get pregnant on them. And, because by the time the 20th week, the drug is already out before they can be transferred to through the placenta. So it's a very good option for these patients to be on B cell therapy, because it has a long action, it covers through the pregnancy, and you can start it immediately after the breastfeeding is over.
Perfect.
And for ofatumumab, actually, it is one of the only drug which is approved in breastfeeding. So once the 10 days are over after the delivery, you can actually give the ofatumumab immediately.
Yes, we have a lot of drugs that are now compatible with the pregnancy, and now also compatible with breastfeeding. So it gives our patients lots of options as well. I'll go back to Gina a little bit and ask you, how would you handle patients who have some rebound disease activity, and how would you, in general, advise them or try to avoid flare-ups? What would be your best tips around that?
Generally, when the relapses are occurring, this is the most complicated phase, because they are on a DMT and they do expect no relapses, but this is generally those patients that are on moderately effective medications, because again, when we do start them on highly active DMTs, they're less likely to have a relapse. But when they do have a relapse, it's the most frustrating for our patients. So how we generally counsel them through it is basically stating that, you've done all that you can. We've given you your steroid treatment for 5 days. We need to have you, recover from it. And the next conversation would be escalating your DMT to a higher efficacy medication, and that they will improve over time. And that it's important for them to understand that they haven't done anything wrong. There's nothing they can do. But most importantly, just reiterating to them that someone is here for them to talk to them, because they are very frustrated that their numbness is still there, or their weakness is still there, or their vision hasn't improved 100%. But this highlights the importance of starting a very effective medication from the start. If they were fearful and only on a platform medication or moderately effective medication when they already have a high lesion load, it gives us more opportunities to be able to convince them to start a high efficacy DMT at this point.
Of course. And also definitely ensure adherence with drugs that are being taken at home, if by any chance it's not an infusion therapy or
exactly
drugs administered at home. So, okay. With that, I think I'll ask Dr. Muna also one question as well. So they're asking us as well, which is a very valid question, but I'm sure you'll give us some insight on that. So for patients who are unresponsive to DMTs, so we're probably talking about breakthrough disease, can we combine treatments by medications with different mechanism of action?
Unfortunately not. So we still don't have that data, and it is a little high risk to do that. So we don't combine data. So we actually switch to very high efficacy medications. And if the high efficacy medications are not working, then you still have the very, very high efficacy treatment, which is bone marrow transplant, autologous stem cell therapy.
Just
so
like
we
we
should not
mentioned at the
shy
guideline.
away from that, actually. And the earlier you do it, the better results are there.
Exactly, exactly. So we always have options in the guidelines if we're following the guidelines, and as we said, we're rarely and more this is not often that we get cases that are completely unresponsive to all kinds of therapy, and we always have to question is the diagnosis correct when we have such bad lack of response, or did we miss something, or is something being not under the radar or something. So as you said, we have to be careful, cautious, and definitely re-question ourselves, and always know that we have options, and there's also off-label medications and options that are being studied as well, and clinical trials too. Okay, so I think with this, I will end. I don't know if any of our speakers have any comments or would like to add anything that we did not.
I would like to add, and I think I would congratulate Gina. I think fantastic presentation. I mean, there's a reminder for all of us that these are actual patients. They are human beings. They need to just have a ear. We need to listen to them. And I think talks like yours should be done in every forum, because this is our main job, and we should be reminded that it's not only about medications and drugs and tests, but it is a human being who just wants to be heard. So thank you for that. And I would congratulate Joel and Maya for this fantastic program.
Exactly. As we always say, we put really the patient and the family at the heart of all what we do, in terms of when we, draw the diagram of how we're supposed to work as a team. It's always about the patient and the family in the middle. So we do all this for them, and improving how we communicate and how we talk to our patients, and humanizing the patient, and really listening to patients' stories is very important. So, of course, thank you to Gina and to all our speakers today. I think everyone did a great job, and I'll leave the floor also to the other speakers if you'd like to add anything.
No, I just want to say that, as Dr. Mona said, also the importance of such discussions and such activities. We have multiple profession, and this mainly highlight the importance of multidisciplinary management for the treatments of complicated disease like MS. So this holistic management approach, from the perspective of the pharmacist and the nurse and the neurologist, who are at the heart of the MS treatment, really should be always highlighted, because we know no one healthcare professional or one physician or even one nurse can take care of the MS patient, because the MS treatment is very complicated. We only talk today about disease modifying therapy, but we know that it's not only this. So we have also the symptomatic treatment, we have the non-pharmacological treatment, we have the treatment of relapses, the support, the social support, the psychological support, and much more, that no one single healthcare professional can take care of all this. And that's the importance of being all together, working hand in hand and collaboratively to optimize and elevate the care of our MS patients.
Okay, so
thank you so much.
Thank you.
For this, I would like to again thank all our panel today. I'm always very proud to have a full panel of women join me. It's always an honor. So thank you for having stayed with us up until now. We'd like to remind you all that you'll get your CME certificate 1 week after the end of this webinar by email. So again, we'd like to thank the CMSC, the Consortium of MS Centers, for endorsing this program and supporting us always. We'd like to thank Novartis for sponsoring this educational activity, and without their efforts, we couldn't have pulled this off. And of course, thank you so much to IVPN for always organizing such educational activities that bring us all together and increase the level of education we provide to all healthcare professionals in the region, and thus improving the quality of care we provide to our patients in the MENA region. Thank you all, and please don't forget to follow us on LinkedIn and all our social media platforms as well. Thank you, and good night.
Thank you. Good night. Thank you. Thank you so much. Bye. Bye.
Bye.